Hello and welcome. I'm Jane Austin from Health Performance Council Secretariat. Thank you for joining us today. In this webinar over the next hour, Dr. Stephen Duckett, who is a member of Health Performance Council, will present the findings of the Health Performance Council review of Country Health Advisory Council's government and ask for questions. If we take a moment before we begin today's webinar, and wherever you all are, we acknowledge and pay respects to the traditional owners of the land on which we all meet, and we respect the traditional owners' spiritual journey and with their country. For those of us gathered in Adelaide and at our HPC office, we acknowledge the Kaurna people as the custodians of the Greater Adelaide region, and that their heritage beliefs are still as important to the living Kaurna people today. So can we look at the slides? Just a quick... So how do we look at the slides, Abdel? Super. So if we could scroll through, just quickly scroll through to the webinar kind of housekeeping, which is 2 slides in. Thank you. So I'm just letting you all know that we are recording today's webinar, and the intention is that we can put a web link to the HPC website, and Country Health can too if they wish. And that means that more of your colleagues can have a listen and interact with the report and with Health Performance Council. There's a couple of moments of housekeeping. If you could keep your phones on silent, and as Abdel said before, muting your video units when we get to question time. I don't think there are any fire alarm tests scheduled today. There aren't any in our Adelaide office. If you hear a fire alarm, follow the local directions. When we get to questions, I was going to start with the questions that were submitted when you registered, but we really didn't get any. And so I think what we'll do is go region by region. So I've got a list of where everybody is sitting, and we'll go through each site and ask for questions. So the purpose of this webinar is giving you pre-release access to our findings and the advice that HPC is going to make about country HACs and governance arrangements. And the intention is that the full report will be posted at the end of the first week of September to our website. So now I'm pleased to introduce Dr. Stephen Duckett. Dr. Duckett's been a Health Performance Council member since 2012, and in his day job he's the Health Program Director at the Grattan Institute. Dr. Duckett was one of the 3 project sponsors that HPC had for this review and chaired the project advisory group. And today he joins us from his desk in Melbourne. So over to you, Stephen.
Thanks, Jane, and thanks everybody for joining us. This is an experiment for the Health Performance Council, but we wanted to give you a chance to hear from us directly something about the report. I'd also like to acknowledge the fact that where I'm sitting is the part of the traditional lands of the Wurundjeri people of the Kulin Nation, and pay my respects to their elders past, present and emerging. Just a bit of an overview about the Health Performance Council. We've been set up now for a number of years, and part of our job is to evaluate aspects of the South Australian healthcare system, and also to make that information available to the public. We have a very important report that we publish that is now available on the web called State of Our Health, which provides a lot of information that underpins many of our reports and many of our findings. But in this particular case, what we were doing was looking at the way country HACs are governed, and the governance arrangements, the relationship between the country HACs and South Australia Country Health Program. And it involved a number of approaches. We started with the context to the 2011 review findings. We did a number of other studies, and we then formulated a report. And so what I'm going to do is tell you much more detail about the report. But before I do that, I'll just give you a bit of a background of the Health Performance Council. So the next slide, please. So we were established about a decade ago. That's nice music in the back. Nice if we could not have it. and we're required to provide a comprehensive report every 4 years. This year, we've identified topics that we're going to be reporting on, and you can see those on the slide. And one of those, or two of them, are actually revisits of reports we've previously.
Sorry, can I interrupt? Whoever's got their microphone not muted, can you please mute it? So whoever has a microphone that yep, that sounds a lot better. Thank you.
Yeah. So two of the reports we are doing are revisits of previous reports where we said, okay, we've done this. We did a report a couple of years ago. The government or the department responded saying they're going to do this. Well, let's now look at it again. And so one of those is this one, the review of the country health governance arrangements. Next slide, please. So our functions are specified under the South Australian Healthcare Act, which was passed 10 years ago. And part of our job is to have this external perspective looking at the whole of the South Australian health system. Our membership is quite broad. We've got people from all over South Australia, people from outside South Australia, such as myself, people who have Indigenous background, men, women, people with health expertise, clinical clinicians, people who are policy expertise, people who are consumers, and so on. One of the very important observations we made was, the amazing dedication we see in the HAC members, both in how much they were willing to contribute to us in this review, but more importantly, how much they actually contribute to their communities and their commitment to helping their communities. In our final report, you'll see a number of fantastic stories that are about what the HAC has been able to do, what the way the HACs right across South Australia have been able to contribute to the health system, to improve the health system for their friends and peers, for the people like them, and the services that serve people like them. So our report our first report on this topic was 2011, and there have been some changes since then. And indeed, even during the course of this study, there have been some changes as well, the new participation framework being the most obvious one of those. So Country Health has now got a community and consumer engagement strategy and so on. So these are all very positive developments, but to some extent they don't change the underlying findings that we found. Next page, please. So what the critical findings are summarised here, and some of them are pretty obvious, that the country HACs promote the general interests of the local communities, the health system, and they do that. And they do that, as we found some really great examples that we've talked about. But often, though, the promotion of the interests of specific population groups, possibly, such as Aboriginal people, is limited, and to some extent, so too with culturally and linguistically diverse populations. A second finding was that the country HACs often have a low profile in their community, and their efforts are not well supported or promoted by the health system itself. And the third finding was that the level of satisfaction with governance arrangements appeared to be low, and finally, the quality of communication was variable. Next slide, please. So in terms of the scope of the review, we looked at, in scope were the 40 country HACs, that's specifically the 39 HACs and the Country Health South Australia LHN Governing Council. We also were specifically looking at what we'd found in 2011, but out of scope were a whole lot of other things like HACs outside Country Health, Country South Australia, and so on. So that was what we looked at. And we were looking at questions like, what is the role of the country HACs? Does it include activities to improve health outcomes in local communities? Do the country HACs have access to adequate information to perform their function? So we're concentrating here on governance arrangements and how effectively can they be engaged? How effectively can they provide advice about their local communities? What sort of information do they have to provide that information other than just what they've got from their own networks? What processes does Country Health South Australia have in place to receive, evaluate and respond to the advice they receive from Country HACs? What's been improved to help to build the capacity of Country HACs to do this? Sometimes this capacity building is called building health literacy, building the understanding of the health system and how health is created or not created. So there are a number of questions we looked at of that sort of governance kind. Next slide, please. Now, this was quite a broad-ranging review, and so we captured information from a variety of ways. We started with just 15 phone interviews just to dip in to see if there was a problem that was worth looking at, and just to get a quick snapshot of what was happening. And we've heard when presenting some of our interim findings that some of the HACs and country communities would have preferred us to offer regional face-to-face meetings to collect more data, but we've tried to capture the data in a range of ways, including through those phone interviews. And one of the other things we did, partly in response to that, was to have focus groups where people we'd engaged went out to 6 of the HACs and had small focus groups to try and understand in a deeper way some of the findings. Another thing we did was look at 17 of the annual reports and documents from HACs to see what they were saying about themselves, what they were saying they were doing, how they described what they were working on, and so on. We did surveys of Country HAC members, 49 people responding, 73 country health staff responding, 44 community members responding. Now, those numbers aren't great, but what was interesting about those numbers is how some of them were very, very consistent in the findings, and I'll be talking a bit more about those findings later on. And as I said, we also had these fairly great range of case studies about some of the things that are actually going on. So we had multiple methods of trying to get a grip on the issues, and you'll be able to, in a sense, judge for yourselves whether we got it right. Next slide. Obviously, every study has some weaknesses. When I talked a few minutes ago about how many responses we got, 49 from the Country HACs. Some people said our survey that we put out was way too complex, and that was partly because we're overly ambitious, I think. Simultaneously with our review, the Legislative Council said it was going to do a review, and we're trying to actually see if we could provide input into that. And so we had our initial timelines were quite tight. We've relaxed that a bit. And of course, one of the weaknesses of low response rate is that you might think that the results aren't really meaningful because they're not truly representative. But as I think you'll find that there was a fairly high degree of consistency in the responses, which suggests that we were probably tapping into an underlying truth in what was being said. Next slide, please. So what we did was we looked at a number of governance elements. Obviously, the HACs can only function, or the HACs function within a particular remit. There's a role that they have, and that's specified, and it's also specified in their charter for their establishment. We wanted to look at how the Governing Council works and the presiding members panel. How do relationships work between Country Health and the HACs? Do the HACs have the right skills, training and development, and so on? So it's fairly broad set of governance questions that we looked at. Next slide, please. So in brief, there's some really good things that we found. That basically, the good news is that Country Health staff and sorry, my my computer is just frozen because I haven't been for too long. So the Country Health Staff HACs have a shared vision for future collaboration. And so, this is a really good foundation for moving forward, that they, both the consumer side of the world, the country HACs, and the provider side of the world, the service delivery people, believe that they're working towards the same sort of goals. And as I said, that's really a positive for us. So on the other hand, there were areas where we could see the potential for improvements. And some of those were about how HACs really fit into the organisational structure, what the role of HACs are in helping to improve safety and quality of health services, and how that role might be described and implemented. Obviously, if the country HACs are to do their job properly, they have to be able to collect information from a range of sources. One of the sources for information, of course, is their own experience and the networks that they live and work in those communities. But another source of information is data. And so, for example, we know that there's a new template, for example, that Country Health South Australia has developed, which is a really good basis for providing or ensuring systematic provision of information to country HACs right across rural South Australia. But there's a lot in there, for example, about financial performance. But there's not the same rigour about quality and safety performance. So, and that's probably true in every state in the country, as a matter of fact. But, so there's room to improve the performance data that's provided to HACs, so they've got a better feel, a better understanding of what some of the issues are in the services about which they are commenting. And so they then have not only their own experience, but can look at, is there experience that they know about? Is that actually consistent with the data that they see that's coming to them from Country Health in this routine report? So it might say, here are all the falls, and that's good, but what are some of the other things that they might report about? And so the value of country HACs will be much better if they've got more information that they can use to provide advice about. And so, and also by providing more advice, providing more information, you'll increase the skill basis of the HAC, and so its advice in turn will be even more valuable. Now, as I said earlier, one of the weaknesses we identified was some of this issue about the general interest of the community versus specific groups. So, moving from words to a few numbers. Next slide, please. So this slide is about some of the perceptions about where we should be going. And so we used, in our report, we used a framework called the IAPP or something like that, the International Association of Public Participation, where they have a framework which talks about levels of public engagement. And the lowest level, of course, is no engagement whatsoever, that the public are just treated as mushrooms. They don't know anything, they're not engaged. The next level up is inform. And what you see on this slide is that that 23% of the respondents here were saying that this is the current level, that basically the country HACs are told about stuff. And the next level up is they're consulted, that their advice is sought. And then you go further up, and empower, which is the sort of the top level, is where they make all the decisions. And the level immediately down from the top level is collaborate, which means they work together to jointly sort of develop options and preferred options but the formal decision is someone else, the empower person. Anyway, what's quite interesting, if you look at that graph, you see, as I said, about 23 see the current state as inform, about 16% see the current state as consult, and few see the current state, almost no one sees the current state as empower, which is probably reasonable, and about 14% see the current state as collaborate. But what's interesting is how this aspiration for a move towards more involvement, more engagement, more at the involve level, the collaborate level. And so a third said, look, where we ought to be is collaborating. And this, of course, if we're going to do that, we have to have more information and so on. And what's interesting is when we asked the country health staff and the HACs, they more or less said the same sort of thing. They wanted more, both wanted more engagement. The country health wanted to use the HACs more. The HACs wanted to be engaged more. The HACs wanted to be involved in these decisions more. And so I think this is a really positive side. There were, however, some differences in opinions about the extent to which the HACs were able to advocate community interests and whether they provided sound advice. But we're starting from a very, very positive base. Next slide, please. Then we asked not only that last question was the sort of the facts, what's happening now, but we asked questions about how well the local HAC is at performing its functions. And here we see the results of that. So, are they competent providing advice on the development and information of systems? Are they competent, good at providing advice about health issues? Are they providing sound advice on the provision of health services? And so on. And unfortunately, this was the community members were the most frequent response of the community members was, you know, they disagree that they're providing the heavy mark there is the 20%. I think, according to my slide, I better look at it very carefully. Is the bottom one is the heavy one is strongly disagree, then it's disagree, then as you move up the scale, so that you've got quite a significant minority there on the disagree that they're doing the right things. But as you move across to the right of that slide, you know, there's a lot of people are saying quite positive things. A fifth of them saying they strongly agree that they're good at acting as an advocate to promote the health interests of the local community. Another quarter saying they agree that they're good at acting as an advocate. So, you know, the country HACs themselves are saying, we think we're doing an okay job on these things, although there is a substantial minority saying not so. Next slide, please. And here we have an example of the disagreement between country health and the country HAC presiding or general members. They have quite different views about the skills they've got. And so you'll see here that just look at the different colours. The lighter colours mean they've got the needed skills, and the darker colours mean they probably don't have. And so you'll see that country health, there's more of the darker colours saying they either won't say or they strongly disagree, whereas the country HAC members think, look, we're okay. We think we have the skills to do what we're supposed to do. And so this difference in perception probably means that there's a tension in what country health is prepared to ask country HACs to do. And of course, one of the solutions to that is that, you know, country health needs to build the skill base of the country HACs, and that includes providing better and more information, for example. And also it means that over time they'll trust them more and recognise that the value of the advice they're getting and the value of the skills they've got. Now, it might also mean that there are different perceptions in what they have to do. So if you've got quite different perceptions, if Country Health on the one hand and the HAC members on the other think they have got quite different functions, they might think they've got quite, the one group might say you don't have any skills for the functions I think you need to do, and the others say, well, we think we have to do different functions and we've got the skills for it. So it might be a different perception, focus of a different perception in roles. And importantly, the functions are actually specified in legislation. These are not something that, you just sort of walk into a meeting and say, oh, I think we ought to be doing this. You actually walk into a meeting and say, here is what the Act actually says our functions are. And the first of those, for example, is to act as an advocate to promote the health interests of the community or a section of the community. So they've got quite clear and quite actually broad functions that need to be provided. And so, we need to tease out to some extent why there might be this difference and what can be done about it. Next slide, please. Now, and everybody was also asked about how their local community values the HACs. And basically, again, if you look at the extreme right-hand side, which are the Country HAC members, they thought that their communities valued themselves quite well. Community members, incidentally, weren't quite as positive about the HACs as the HAC members themselves were. Now, this might be because the community members didn't know about the HAC, or they didn't know what they were doing, or whatever. And so you've got quite a few there in that dark boxes, again, are the disagree sort of boxes. The 30% there in that middle bar are the strongly disagree that they value the HACs. And again, on the left-hand side, the Country Health South Australia people were actually less negative than the community members, but actually more negative than the Country HAC members. So there's different perceptions about how the local community itself values the HACs. And this, of course, is consistent with what we found in 2011, which is a bit unfortunate. So we think that the Country HACs ought to be actually foundational, and they should be considered a critical part of the provision of locally grounded advice and support through the Governing Council and so on to ensure safe and high quality patient care. And maybe there's, as I talked about in the previous slide, some differences in perception. Sorry. And so there may be some differences in perception of functions, as I talked about in the previous slide. And so this might mean that we need to be more explicit of how the Country HACs fit into the organisational governance arrangements and so on. And so this is one area of change. Next slide, please. So one of the things I've talked about and alluded to a bit already is how the HACs are supporting Country HACs strategic directions and so on. So next slide. So this is an organisational chart. Now, organisational charts are probably the most boring things in the world to look at, and I apologise for this. But what's interesting is where Country HACs sit in the organisational chart. And you can see them on the extreme left-hand side there of that slide. Those three pink boxes are related to the HACs, Health Advisory Councils are there, reporting in a dotted line relationship to the Country Health Strategic Executive and through the presiding members panel and the Governing Council. Now, what's interesting is really the value add of the HACs is the value add locally and through that local understanding and local engagement. And there doesn't appear to be any link to the local world. And so it's really this organisational chart is somewhat symptomatic of some of the problems there about how the relationship ought to work and how it ought to be strengthened. And we couldn't see, I said earlier that we did a review of these documents from this sample of 17, I think it was, country hacks, and we couldn't find any reference anywhere to this link between the hacks and local hospitals and healthcare facilities. And these are people who are cheek by jowl in the supermarket. I mean, it's really quite interesting what we actually are seeing there. The other interesting thing is that we found the governing council functions are, to advise country health are limited to hack references on financial and liaison roles, which probably isn't consistent with best practice nowadays about what you're expecting, because at the very least you need to think about quality and safety at the same time as you think about financing. Next slide, please. So I've talked already a number of times about how well sort of the information that HACs needs, and so this is something we looked at specifically. Next slide, please. And here again, we asked HAC members how usable they found the reports and documents supplied by the health service. Now, again, the dark colours mean less useful, or they don't receive them at all, and the lighter colours are more useful, and so on. So if you look going across here, we see that financial information and financial reports, in this particular case, we've got more than half say they're either very usable or pretty usable, and 20% in this mid zone. This is on the extreme left-hand bar. Now, the reality is that's probably true of hospital boards in other states. HACs aren't hospital boards, but financial information is usually better prepared and easier to understand in some senses because it's all quantified, and there's been a history going back 500 years about how you do financial reports. But then when we move further across to the left here, on these different types of information that HACs need to make useful decisions and provide useful advice, we're getting a greater proportion of the darker blue sort of answers. And these darker blue answers are you don't receive these documents at all, or whatever. So what we're seeing here is regional hospital safety and quality reports tend not to receive them as much to the same extent. Complaints and feedback tend not to receive them, although to be fair, the new template that Country Health South Australia specifically has information about complaints and compliments, for example. So to some extent this might be addressed into the future, but who knows how well that's going to work out. Regional health outcomes, regional patient experience surveys, and information about staff. I'm sorry I'm coughing all the time, but I'm just at the tag end of what my partner calls man flu, so you're getting the worst of it. And of course, this is something can be remedied because all of these reports exist. All of these reports can be actually made more usable, more user-friendly, and we can also build up the skills of the Country HAC members to understand them better, and so provide better information back to to Country Health South Australia on what some of the conclusions and findings are. Next slide, please. So as I said previously, we looked at the skills necessary to perform the functions as specified in the Act. And unfortunately, again, we're seeing a divergence here between Country Health South Australia and members of the HACs, where the HACs think by and large they've got the right set of skills, but the Country Health South Australia doesn't. And of course, the response to that has to be about building up those skills, and if Country Health South Australia or its staff think that the the country hacks don't have the right set of skills, well, it's partly Country Health South Australia's job to actually say, okay, we need to develop these skills, because you don't find a random person on the street and say, oh, we want you to do this, and with no preparation and background. And it's something that, you know, you gradually move into. I mean, I previously was a board chair here in Victoria, and we had a community advisory committee, and, you know, we chose the members of the community advisory committee to have good links with their local community, but we recognised that part of our job was to help them understand better the hospital, understand better the constraints we're under, understand better what some of our issues were. So it was a two-way street. As we were developing their skills, they were helping us understand the issues of the local community better. And so, you know, these things develop over time. Next slide, please. As I said right at the start, there's been some welcome developments since we started on this process. The new partnership framework has been released, which is really good, and it really provides a useful platform to take forward the recommendations and the findings of our report. We believe that, as I said, that this is a worthwhile framework, and it's part of the improvement journey that the HACs and Country Health South Australia are going to need to pursue. And interestingly, you know, the way this was developed is good in itself. That when we talk to members of the HACs, they often, a number of them referred to this welcome development, and that they had been engaged in developing this. So it in a sense, maybe not perfectly, but it provides some hope that good things can come out of this partnership, and good things can come out of the listening to the advice. And the HACs are really quite, the people we spoke to generally are quite pleased about it. I'll just mention as a side, when I worked in Alberta for a number of years, a while ago now, and I was the CEO of what was called Alberta Health Services, which provided health services to a population of about 4 million people. And I had 10 KPIs, which were in my performance indicators, which determined the size of my bonus. And one of them was about the health advisory councils, which were equivalent of the HACs, basically. And it was about to what extent, surveyed of the HAC members, to what extent they felt that their views were being listened to. So one of the 10 of my key performance indicators was about making sure the health advisory committee, that we were tapping in to the views of the local community, because of course politicians, after all, who run the system or are responsible for the system, really want to make sure that the system is responsible. And so that was part of my job to ensure that was happening. Next slide, please. So we looked at also community and consumer engagement. Next slide. And we looked at the perceptions of the value of the work that the HAC did and their current engagement levels, and what the level of engagement of the HACs should be. Next slide. And as I said right at the beginning, we had this IAPP document which guided us, and I mentioned already this inform, consult, involve, collaborate, empower, which are stronger approaches to public administration, or to community public participation, community engagement. And we use this as our framework. Next slide. And I've already talked a bit about some of this, about how well this engagement occurred and what level it occurred at. And what you see again is how much of it is, or the differences in perception, and in terms of how well their HAC has been engaging with key groups. So the Aboriginal experts, by experience, by and large, were quite negative about the level of engagement. The local Aboriginal and Torres Strait Islander people were also negative, not quite as negative. The local, culturally and linguistically diverse people, again, relatively negative. And so if you recall, right at the start, we said overall, they seem to be representing the views of local communities well, but they don't seem to be representing the views of specific communities, and this is the sort of evidence we had from that. Similarly, with low-income people, people with disability, and so on. But as you moved along, when you got to the end there, which is the local community generally, quite good response. And so you can see the differences there, which led to the negative, the finding we had. Next slide. I've talked a bit about this already right at the start, where this view about moving forward and moving up that scale to have a more engaged approach to the involvement. And of course, this is really good news because it suggests there's a shared vision, you can move forward together, and that's actually very, very positive. And I think it also shows there's scope for much wider engagement with the community. Next slide. We played around with what we called a maturity matrix. In the end, we haven't recommended anything on this, but I think there was some good thinking here in what we did and the work we did and the talking to people about it. But if you're going to move up that scale, not everybody can be at that collaborate level or that involve level tomorrow. And you've got to actually see whether you've got to make some sort of assessment about that. So next slide, please. So we developed a maturity matrix, which had a couple of different levels of what a mature governance arrangement ought to look like. As I said, this is a draft. We didn't end up using it. We've put it in the report as an appendix because we think it was good thinking. Everybody else might think it's useful as toilet paper, but we think it actually helps people understand a development path for what they might want to do on particular aspects. How well have they specified their purpose, function, and behaviours, or how well are they? What are the mechanisms they've established to work with external stakeholders and so on? And what we're trying to say is, over time, we want to see the HACs move towards the exemplar level rather than the basic level, which is, I think, the functions in the Act. So, as I said, we're offering this as part of what came out of our listening and our advice and expertise. Next slide, please. So I've in fact already talked about this. These are what you saw right at the beginning. The good news is the shared vision, the need to get more into the patient safety and quality health space, the need to improve the data provision, the need to think more broadly than the general community and thinking more of the interests of the specific populations. So I might leave that slide up there, but I'd like to thank my colleagues, Janine Greenhill and Mary Patessos, who were members of who were the other three people who were members of the Health Performance Council who sponsored this project. We also had a fantastic project advisory group we had some pretty robust discussions, and they were very, very helpful for us in informing how we approach things and giving us useful on-the-ground advice about whether the questionnaires would be understood by HAC members and so on. We had, in particular, we on the panel was Jeanette Brown from Country Health South Australia, Dennis Clark from the Local Government Association, Ellen Kerrins from the Health Consumers Alliance, and Barry Moyle, who is a member of the Country HAC presiding members panel. Of course, all of this couldn't have been done at all if we didn't have people responding to our surveys, if people weren't prepared to attend the focus groups. So that has been really valuable, and so that was useful for us as well. Now, the full report will be posted at the end of September. Later, the slide information, an email for you, but I'll stop there. I'm sorry I went so long, but are there any questions? Jane, over to you to moderate questions.
Thanks, Stephen, and thank you everybody for your attention. So I have a list of the sites, and my advice from Country Health was to simply go around the sites asking for questions. I'm going to, I'll start with Edward in Cooper Pedy. It doesn't look like Edward is still there. So I just wonder, I'm going through the list. So Port Augusta, are you still there, Karen? Craig.
Karen wasn't able to attend, but we don't have any questions, thanks.
Thank you. Just forgive me for making, I'm just trying to make sure I don't forget anybody. Mount Barker?
Yes, thanks. Can you hear me?
Yes.
Yeah, okay. It's Jeff Fuller here from Mount Barker, a member of the local HACs here and also a new member of the Governing Council. Look, thanks, Dr. Ducker, for your presentation. Now, it's pleasing to see what is coming out. I do agree that the new reporting template does look good that the regional directors provide to the HACs. But might I say that if one can think about the way that information is given, if it's possible that information can be sort of structured or presented in a way that's two-way. And by that I mean that one can receive a report, a couple of pages, that's okay. But it might also be useful if when those reports are provided that the regional directors or the planning officers in each site can sort of draw attention to those bits of information that might be notable. Now, notable could be that things are really good, or it could be areas where there's some deficiency. And then to put to the HACs, what are the things that the health service is wanting comment and advice about in relation to those notable bits of information. So in a sense, it's really just adding to what is currently happening in terms of new developments, but maybe adding an extra process in there that enables the HAC to focus on those bits of notable information.
Yeah, that sounds a good idea. Look, the template is new. It obviously will evolve over time, and I think ideas like that are good ones. Maybe we could pass that on to Country Health South Australia.
Thanks. Gawler, have we still got Gawler?
Hello, we're here. This
Yes.
is Prue and Bron, and I'm the presiding member of the Gawler HAC. Thank you, Stephen and Jane, for the opportunity today. It's been fantastic hearing it firsthand. My question, Stephen, is around the difference of opinion of Country Health staff and HAC in the school level, and your conclusions focus on improved performance data, or improved data generally. And whilst I absolutely agree with that and agree with Jeff's earlier comments, I'm wondering why you didn't focus in the recommendations around training opportunities. If you apply the IAP2 framework to the HAC members with a training focus, there might be some interesting that might augur towards the coalescence of the Country Health staff and HAC members in a better understanding of where the skill set should lie.
Prue, that's a good call, and we certainly do talk about training and development in the report.
Right.
So it's my fault for not mentioning that in the presentation, but certainly that's one of the things we did mention.
Thank you.
Thanks. I'll move on to Victor Harbour. Do you have any questions?
Hi, there's four of us around the table. Can you hear us all right?
We can hear you and see you.
You are very good. My name is Kay Suvato. I am getting a strong sense that I actually would really like to see a HAC member selection criteria be identified, which identifies the skill sets and the experience that is required. So when you're doing the recruitment of Health Advisory Council members, for example, in the Southern Fleurieu region, it would be useful for us to have a set of guidelines for doing that recruitment, because I think currently we rely very much on who is prepared to put and invest their time and energy into being involved in the Health Advisory Council. And I think we have tried at Southern Fleurieu to be clear that, you know, we need people with certain skill sets, but it's not. It would be good to have a consensus around the Health Advisory Council as to what that might be. Just another comment from me, and I'll just shut up. That is, we certainly were not involved in the development of the partnership framework. We heard about it serendipitously, what I think I'd like to see is what you're referring to is the reporting framework, because I certainly haven't seen that, and I think my colleagues around the table haven't seen that as well. So we haven't had an opportunity to contribute to it.
Thank you. I think we could take that as a comment. Do you think?
No, I'm happy to. Well, the latter bit, the second part, is certainly a comment that we're obviously not involved in that. But on the skills and experience, I think that's a good point. That when you're making the appointments to the HAC, you need to balance the skills that people come with. What is their skill set they're bringing? You know, are they a lawyer person? Are they a clinician person? Are they whatever? You need to bring what sort of experience they might have had, how long they've lived in the local community, whether they come from a culturally linguistically diverse background, an Indigenous background or whatever. So you've got a number of sort of what their age group is, what the gender is. You've got a number of factors that you want to take into account to get a good mix. As I said, when I was chair of the board of the Alfred here in Melbourne, it was really hard to find a small enough group which was diverse enough that you could tap into the quite different populations that we were serving at the Alfred, and we had another hospital called Sandringham, which was a small community hospital, and so it was really quite hard to get a mix. But I think your point about being clear about what the mix would be and what sort of things you're looking for is a good one. But you've always got to be careful that you may not find these people, but you always should be on the lookout and advertising and trying to use local networks to tap into people. So thanks very much for that, Kay.
Thank you. I'd just like to add, I think, because one of the really important roles is for members of the Health Advisory Councils to be a link with the community and the health service, that we also need in any kind of criteria to identify the capacity of those people to actually be networked into the community and their preparedness to engage with the community.
Exactly, Kay.
Communication.
Kay, I couldn't agree with you more that you don't want just an individual who just comes and expresses their own individual views which may be totally and completely idiosyncratic. What you want are people who are networked in so that you are tapping in the views of a much broader range of people than are sitting around that table. But as I said, you've got to be careful that broader range of views is heterogeneous. That is, you're capturing culturally linguistically diverse, you're capturing Indigenous, you're capturing young, you're capturing old, and whatever. So it is very, very hard, but really, really important point, Kay, about making sure they're networked into their local.
Could I also, without wishing Victor Harbour to hog this, but I had 2 points. I'm Peter Davidge, been on the the local hack for about 18 months. One of the things, 2 points. One that really concerns me and concerns the rest of the group here is that the data and information boundaries, where there is data and information available, does not line up with our hack boundaries. So we get regional information, which is clouded for us, if you like, with information from other areas that don't line up with our boundaries. So that's the first point. The second is that I didn't hear you mention to any great extent resourcing issues, because many of these initiatives will fail because of 2 things. Firstly, the Country Health has not the resources to promote these things, and secondly, that the HACs have not got sufficient resource to assist them with administrative processes, providing advice, engaging with the community, etc.
Yeah, thanks, Peter. Both of them are really important and critical issues. The boundary one is something that can be, in a sense, easily addressed. As we get better with computers, it's going to be more feasible to develop reports which are tailored for specific purposes, such as the different boundaries. So that is something that I think over time can be relatively easily fixed. But the issue of resourcing is a really quite complex one. We obviously have to function with the resources that we've got, and so too does Country Health South Australia, and so too do the HACs. And to be fair, the HACs are really, really lucky that there are so many people who are prepared to give so much of their time voluntarily because they're committed to trying to improve health services locally. And that's, a tremendous resource. But we've got to make sure we don't waste that resource. We've got to make sure we use that resource well, because otherwise people are going to be peed off and not put their time into it. And their time is what is so valuable. So you're right that we need to be really careful about making sure they're supported well, making sure they've got the right information, making sure they're not wasting their time doing stupid things. And obviously that's something that that can be, I won't say is easily fixed, because Country Health doesn't have unlimited money to fix things, but it needs to look at those sorts of issues.
Yeah, we should be covering travel and other things for people to make sure that we do get that diverse group from right across the region.
Mm-hmm. Thanks.
Thanks. I think we will need to move it along. I've completely failed as chair in that we're 12:30, and I do know that there are more people with questions. Can I just say, at the end of your slide deck, there is a contact information for the Health Performance Council Secretariat. So if there are people that need to leave us on the hour, then please send your questions to us and we will address them out of session, and I can share them with everybody as well. So for those who have to go at 12:30. If not, can we crack on to there's no one in Strathalbyn Hospital. I can cross them off, I think. Port Broughton. Is there anyone at Port Broughton who would like to ask a question? Hello.
Yeah, hi Jane. Thank you, but no questions from Port Broughton.
Port Broughton. I've got Glenside Content Server. Is that really
Just
a place?
ignore that.
Ignore that place, sorry. Berry? Hello. There's Berry on the screen.
No, we don't have any.
Oh, thank you. I don't want to put anyone under any pressure now that I've made the time pressure. Lamoureux.
Hi, I don't have a question, but thank you for the opportunity, but I do have a comment. Each HAC is provided with $5,000 a year, which can cover things like education and attendance at conferences. A lot of the HACs used that this year to attend the annual Country Health Conference in Adelaide, so we do have some support. Maybe it's not enough for the larger communities, but there is some support there. Thank you.
That's good.
Thank you for the comment. Narracourt?
Yes, just switch microphone on. Barry Moyle. I'm
Hi,
chair
Barry. How are you?
I'm good, thank you, Stephen. It's nice to see you there. We just remarked how we thought it was Ronnie Barker, actually.
You're not the first person who said that, actually.
Yeah. Thank you, Stephen. One thing I would say about recruitment and so on is that we've got to recognise that country people are very diverse and also very knowledgeable across a broad spectrum. Country people mix and match with a lot of, and I've said this before, and it's one of my hobby horses, they bring a skill set of their own. I mean, and I relate it back to local government selection. And I won't go there, but we should recognise the skill set that people bring to the job. The other thing I'm going to say is a difference between boards and health advisory councils, and I was part of it when we changed, and we were taught, and it was part of the process with the change, was that with a board you stood on the veranda of the hospital and looked inwards at the functions of the hospital and et cetera, finances and all those sort of things, and at the same as a health advisory council, you stand on the veranda of the hospital and look out at the community. And what can we do for that community? How can we bring them on board? And I think as a Naracoorte hack, and I'm extremely proud of what this body has done, we have achieved. And thank you for using one of the submissions, reference to our CT, and I'm like a cracked record on that. But yeah, I'd just like to say that. Thank you, and it's nice to see you face to face, Stephen. Thank you.
Thanks, Barry.
All right. It's at Hawker Hospital. Is there anyone in Hawker? The room looks empty.
The room looks empty.
I just might add, as I said earlier, Barry was on the reference group, but we met on teleconference, so that's his comment about seeing me face to face. Thanks.
Well, now we've got Jabba on your computer. No excuse. We can just do this on video conference. Sorry, back to Mount Gambier. No.
Hi, I haven't got any questions, thanks.
Oh, okay, thank you.
Thank you.
And now I've got three left, and I'm afraid I'm leaving Country Health Corporate Office last. At Corn Hospital, do we have Corn?
Hi, no questions. Haven't got any HAC members, unfortunately.
Well, you can ask a question too if you have one.
No, that's all good.
Okay.
Thank you.
And Maitland Hospital, which is I think where Peter is.
Yeah, I don't know whether you get Maitland.
Hey, Peter.
And I've had two HAC members with me for most of the meeting. One unfortunately had to leave. But yeah, thanks, Stephen, for that report. I can see that you've made considerable effort to try to negotiate and work with people, but I have to say that the small percentage you're actually able to get to does skew the report somewhat. But I will say that it's a lot better than the previous report. However, I guess my concern is that on each time of the last 4 or 5 combined conferences we've had, HPC is asked to have a part of that conference each time those reports have been given. And the last one that we had, there was, and I wasn't present at that subset meeting, there was considerable feedback of a negative nature. And that worries me because the good work that you're trying to do is obviously not getting the message through. And hopefully you'll be able to take on board some of those comments that were made at that time and move it into the system if you can. And I guess at a meeting we had on Tuesday, I was a little concerned that reference in the proposed report is fairly light on in the partnership agreement, and then it was pointed out that there was reference there on page 83. Well, that sort of highlights the importance that you've placed on it, that you've put that good work at page 83. Now, since then, reading through, there are brief references elsewhere in the document. The other thing that I would say is that I don't think the Governing Council were actually consulted in this. The reference that my name's mentioned on a few of the references, nearly all historic, and I'm from records that go back, in some cases, many years. And I'm a little concerned that wasn't taken into account. The presiding members panel is a subcommittee of the Governing Council, set up by the Governing Council to improve the HAC Governing Council relationship, because, as you will recall, the original board that was there was very much representatives from each hospital around the state. Not each hospital, but many of the hospitals around the state. When the federal-state financing arrangement came in and the Governing Council had to be converted to a skills-based board, we lost all of that community representation, and consequently the Governing Council established the presiding members panel to help bridge that gap, to bring that communication in. Now, I notice in the report, the draft report, there is a different slant on it than that. However, the important part is that we need to be consulting at all levels. I did make brief mention about the limited nature that you have in having the process that you use. There is no substitute for getting out amongst the people. I do have experience in that. I chaired the group that managed the South Australian Strategic Plan. We did 47 meetings around the country, but we never had a negative feedback from anyone. So there is no substitute for getting out amongst the people, and I strongly recommend that you should do that if you want to make a substantive report for progress in the future. So I don't wish to be negative, because there are vast improvements on this report than the previous one. And it's more conciliatory and it's more open and conducive towards working together. My biggest problem is to encourage as best we possibly can those people who are out there that are busting their boiler to work for the health services, and yet a very small percentage have actually been included in your report. And that's because of the process, not necessarily the individuals who gave that and made themselves available.
Thanks, Peter. A number of points there. With respect to the partnership agreement, we had more or less finished our whole report when that was released, and so we then had to step back and say, well, this is really important and a really positive development. How do we take that into account in our report? And so we wanted to, and we did. The fact that it ended up on page 83 is, just one of the where it fitted into the structure, not because we don't think the agreement is not important. In fact, we do think it's important. We think it's positive, and I've said that in this presentation, but that because of the timing of it, it wasn't really able to come within, easily incorporated into the report. The second thing about the comments you made about the negative feedback, I'd appreciate it if you could speak to Jane further about that so we can get some better understanding of what that might have been about, because I think it is useful to get feedback of that kind. With respect to the Governing Council, I thought we had engaged, involved them through some of the survey work, but obviously not adequately, and I apologise for that. And unfortunately, that is unfortunate, and it's really an important group that we should have obviously engaged with more. In terms of out and about amongst the people, yes, indeed, we did some of that. We had focus groups in various parts of South Australia. We couldn't obviously do every part of South Australia because our budget, like everybody else's, is limited, and so we just couldn't actually go to every HAC. It just was not possible. Although we had in some cases we had them in 6 regions, and so a number of HACs were able to be represented at those focus groups. So that was our way of trying to do that. And so I agree with your point, but we were limited in what we can do. And the final point about more engagement and so on is obviously something we agree with, and it is good that you think it's a better report than the last one, but obviously these things are journeys for us as well as for you. I'd agree with you totally and wholeheartedly about the tremendous commitment that's been made by members of the health advisory councils, and we tried every way we could to get more feedback. We extended the timelines. The feedback we got from the reference group was putting out the survey at this time was going to be no good because of this or harvest or whatever. And so we kept on trying to think about ways we can get better information, more information. But I think overall we've captured, I think, the sense, and there was a strong degree of agreement amongst the responses we get. So I think the small numbers isn't such a problem as all of that. But anyway, thanks, Peter, for those comments.
Okay.
So thanks, Stephen. Now, we've only got a couple of minutes left. Are there people on Jabber who would like to ask a question?
Yes, Steve Richmond here, Mid-North Hack. I don't have the paperwork or documentation with me at the moment, but is it possible we can be sent a copy of the report and the recommendations so we can review those?
Of course. And so,
and discuss that at the Hack meeting, of course.
Yeah. So, Jill, could you scroll forward to the slide that says next steps? So.
And I'm going to get cut off in about a minute, I think, from what I worked out.
Yeah. So, in terms of the next steps, the report is about to go.
No, he's going.
Anyway.
Just go on mute. That's fine.
Anyway, when he looks at his slides. So the full report will be available in September. If you've got any further questions about the report or you'd like to receive a paper copy in the post, can you contact us, please? We will print them on demand, but we're not going to print them and have boxes of them sitting around because I feel for the trees. And I've put the contact details there for our Secretariat office so that we can send you out enough copies for your meeting or an electronic copy, however you'd like it.
No, that's good, thank you. I can't look at two screens at once, so I've got that now. Thank you.
Okay, no, that's smashing. So I think if there aren't any other questions, I apologise for us running 15 minutes.
Can I just make a comment from Whyalla?
Sure, sorry. How come I didn't know Whyalla was on the thing? Sorry.
We had to dial in. We didn't come on automatically, so I don't know whether you can actually see us or not.
We can see you now, but you weren't on my list, so I'm really, really sorry.
No, that's okay. I'd just like to make a comment to say that I feel in Whyalla, it's Santa Claus, by the way, too, we're well supported and resourced by our local management team, so we've got no complaints in that regard, and just look forward to seeing the report when it's released. Thank you.
Thank you. So I think I'll bring this to a close. Stephen. Pardon?
Can I just make a comment?
Sorry.
If this is Riverland here, I'd like to concur with that statement because I truly believe that we are very well served in the Riverland region, particularly in the Riverland, with the information that we're given and the support we get from the staff. And I think people on the HACs are usually very well known in the community and make sure that they get out and talk to their community.
Good.
Right, sorry. And Steve Tully has just reminded me that I forgot about 22 King William Street.
And I'd also say that I forgot about Steve Tully. I didn't say, you're too small there, Steve. I couldn't see you. So I should. Steve is the chair of the Health Performance Council. So it's great that he's been able to be here and listen to everything you've had to say.
Okay, back to 22 King William. I'm really sorry, colleagues.
That's okay. I'm Marie Garrity here, the CEO of Country Health. I had the opportunity to meet with the Health Performance Council yesterday in terms of discussing the report. We welcome the report. I think any information that we can get to improve the way that we engage with our communities and engage with our health advisory councils. We truly value our health advisory councils, and although it mightn't show it on a governance chart, I think that all the health advisory councils would say that the regional directors and the directors of nursing of each of the hospitals are very closely linked with their health advisory councils, and I think attend all of the health advisory council meetings. So it's probably about more formally recognising that from a governance arrangement, but just to say that it really does happen on the ground at the local level. And certainly when I have met with every single health advisory council and continue to do so on visits. But I think there are learnings. There's always ways we can improve. And I think in terms of the partnership document we now have and the information of the template of information that we want to provide to the health advisory councils. And I think there's really big learnings in how we can better support the skills development and how we do engage. So I look forward to continuing to work in partnership and welcome receiving the report when it's finalised.
Thanks very much, Marie. That's very nice to hear, and thank you for the commitment.
Yes, so thank you to everyone who's participated today. Thank you for your patience in us running a little bit over. We've recorded this today, so we'll put an upload to the Health Performance Council website and possibly the Country Health website. So it's available for more of your colleagues if you want to dip back into this webinar. So thank you. I think we'll close. Thanks, Stephen.